grows in self-actualization. So it strives to help the person, but not just the person, their family as well, to address issues, expectations, needs, hopes, and fears, and prepare them to manage and have a self-determination of life and closure for the dying, and helping them cope with loss. So it's a huge, huge area. And it's appropriate for any person and or family living with or developing a life-threatening or life-limiting illness. So due to the diagnosis with the prognosis regardless of age. So it doesn't need to be somebody who's older that's got cancer. It could be anybody. It could be somebody in their 20s with some life-limiting illness. So it's to prepare them to accept the inevitable, I guess, and so that's what we're trying to help these people with. And the values of palliative care are usually the same everywhere you go. So it's compassion and giving that individual choice, innovation in controlling the pain and symptom management, and it's usually an interdisciplinary approach. So you have your physician, you've got your nurses, you've got a whole team, and volunteers are probably one of the most important part in palliative care. Like the volunteer role is huge in palliative care, no matter where you go. And they can be involved in all aspects of the care. So now, in terms of palliative care and hospice, they're really fairly similar. They're both providing comfort. Palliative care can begin at diagnosis if it's a life-limiting illness, and at the same time as treatment. So the person could still be getting treated, but being treated palliatively, if you know what I mean. But hospice care is really once the treatment's stopped. Now, I don't want to confuse you, but there are palliative care beds at the hospital. So they are sort of like hospice. Most of the patients in those beds, the treatment is stopped. There's no cure, and they're being treated as their end of life, and they're being kept comfortable. In the hospital, most of you probably have been there. It's 3 beds, and each room has a big family area. So there's a fridge there, there's a reclining chair. Like the family can stay there 24 hours a day, and they're welcome to. And there's volunteers there too. They're present on days and evenings as much as possible. And the members of the clergy are also available to help with those patients. There's also a chapel right around the corner from the palliative care unit that's open all the time for people. And like I said, the family member can stay with people around the clock. Where I work, it's a small hospice. We have 6 beds. Each room has a private room, and it's like in a garden setting. So each bed has a picture window looking over the garden and looking out on trees. And because of our volunteers, they feed the deer and birds. So you can imagine having a picture window, you're looking out, and most people don't see deer that close, but there they come within 6 feet of the window. And it's just a very, very peaceful setting. The volunteers work on the garden. They have a huge garden, and it's always beautiful, winter and summer. And they decorate the home. And the family can stay 24 hours, and we sometimes have more than one family member, and that's fine too. They can bring animals, so we have dogs, we have cats. As long as they're under control, they can stay in the room, especially with cats. You don't want them running all over the place. So at the hospice, it is a locked facility, meaning the doors are locked. So there's usually a volunteer sitting at the door welcoming people, but letting them in. So we do, it's not that we're trying to limit visitors, but sometimes patients still want to see certain people. So they have that list, and they're kind of attuned to what's going on at all times inside, and they're the ones that will stop them at the door and say, well, they're not having visitors right now, or something pleasant like that. We've also got volunteers working in the kitchen because we make all the meals for the patients. So if everybody's eating, there's 6 meals to make, and so the volunteers really come in handy with that. We've got a counselor, a grief counselor on staff that spends a lot of time with the families. We do laundry, so it's sort of complete care. Once the patient moves in, it's their home, and that's the way they're treated. It's staffed with 1 nurse and a PSW round the clock. And we take patients from the valley, like we don't, like I'm over in Renfrew, so they come from, you know, Arnprior, Dunrobin, like they come from that whole area. There's no limit to who can come. The physicians looking after them are mostly GPs in the Renfrew area that are specialized in palliative care. So there's maybe 4 or 5 that typically look after those patients for us. We've had like weddings, we've had anniversary celebrations, we've had marriage vow renewals. Like there's no limit to what we can do because we're just trying to provide care and do whatever people want. The other thing with our funding, it's not completely covered. So if you see hospices doing fundraisers, it's because they can't cover their costs. We're not funded the way a hospital is. Like, it's probably we get maybe 50% from the government. So the rest has to come on the fundraising to keep the doors open. So our goal is to provide like a calm, supportive environment and care to patients and their families. And even though everybody who comes in, they've agreed that they do not want to be resuscitated. They have to sign for that. They also have to sign that they don't agree to have MAID, which is medical assistance in dying, because we don't provide that at the hospice. However, we still do some treatments because if you suddenly develop a cough and the doctor figures it's pneumonia, we won't probably send you to the hospital for an x-ray, but they might treat you with an antibiotic because it will make you feel better. Or same with lots of patients will get bladder infections. Well, they can still be treated with antibiotics. It's not like we don't do anything. We've had people that even their pain is hard to control, and maybe they were getting radiation before, so they'll go into the city and get a couple of radiation treatments, and sometimes that's all they need, and then they're pain-free. And so it's not like we're not doing treatments, but we're kind of limiting what we do. So, does that answer people's questions about hospice? So I'm going to move on to MAID next. So MAID is medical assistance in dying. Most of you might remember it was 1993 with Sue Rodriguez. She had ALS, which is a gradual, like, paralyzing disease. And she went actually to the Supreme Court trying to get assisted suicide. And the Supreme Court, it was a 5-4 decision against it, which meant that Canada really wasn't ready to kind of discuss it or deal with it. And it was going to require a change to the criminal code. And up until 1970, you can correct me if any of these facts are wrong. Up until 1972, it was actually illegal to die by suicide in Canada. It was considered a criminal act. So after the Rodriguez case, between 93 and 2010, there were 6 new bills brought forward trying to bring in some sort of a law for it, and they were all defeated. And then in 2015, there's a Carter case. He had spinal stenosis, and he went to Switzerland for assisted dying. Switzerland's been known to, they're years ahead of everybody else in providing this. So a ruling came down then as a result of that, that it was unconstitutional, and the Supreme Court ruled in favor that something had to be done. So they gave the government 1 year to figure out something, and it took a while, but in 2020, in BC, they had their first assisted dying here. So it's really not that old, hasn't been around for very long. So Bill C7 governs all of our practices today. So what is MAID? MAID is administering a substance that will cause death, prescribing or providing the substance to a person, either by injection or it can be oral, and it's assisted suicide. So what isn't MAID? It's not the withdrawal of life support. So you might hear somebody say, well, they were taken off the ventilator. Well, that isn't MAID. Or withdrawal of life-sustaining technology or therapy, that is not MAID. Continuous palliative sedation is something that we sometimes do if people are in intractable pain or they can't breathe, so we're sedating them fairly heavily, but that is not MAID. It's basically trying to end suffering, but it's not causing death, it's trying to control the pain, so that is not MAID. So why would people ask for MAID? Well, some people just want control. They want control of when, where, and who is present when they die. Or they might be afraid that they will have poor pain control and poor symptom management. And some people may feel a loss of independence or control over their life, or loss of quality of life due to their disease prognosis. And also a lot of people are fear prolonged dying. So there's many reasons that people choose this. So how are people eligible for it? Well, you need to have health service coverage. So you need a Quebec health card or an OHIP card. You need to be covered by provincial or federal government. You need to be 18 years of age, mentally competent, and it needs to be informed consent. The patient themselves has to make a voluntary request, and they have to have a grievous or irremediable condition. So it means a serious condition, disease or disability in an advanced state that cannot be reversed. So you have to be pretty sick to get it. Or they could be just experiencing unbearable physical or mental suffering from the illness, disability, or state of decline. So in order to be eligible, the patient themselves has to fill in a written application. It has to be witnessed by, and it can be witnessed by a healthcare provider, but as long as the person witnessing it can't benefit from the death. So you couldn't get, if I couldn't get my husband to sign it because he might benefit. It has to be somebody totally independent from the person. And so they're going to put in the request to the healthcare provider. They put in the written request, which needs to be witnessed. And then there's 2 independent assessments done. In Ontario, a nurse practitioner can be one of the assessors and a medical doctor, but that's not the case in Quebec. It's got to be 2 medical doctors. So 2 independent doctors have to do the assessment, and they do it separately. They don't talk about it ahead of time. They do the assessment. And it's up to the patient to determine where and the date, the time, and the location. Totally up to the patient. And they are also given, I might decide today, okay, in 2 weeks I want to do it, but I can change my mind at any time. Just because you say today you want to do it, you can change up until the last minute. So in terms of what do they do? Well, first they give a sedative, and it just makes people fall asleep. Second is a local anesthetic, and then third is a neuromuscular blocker, which basically stops your breathing. So you have a respiratory arrest. The sedative they use is midazolam, so that makes you fall asleep. And then propofol is the anesthetic agent. You probably all remember Michael Jackson. He got a bit too much propofol and he never woke up from that. So like it's a sort of a typical drug that they give during operations, but it's fairly strong. And then rocuronium is a neuromuscular blocker, so that sort of causes paralysis of the breathing muscles and you die. Sometimes they might use potassium chloride because it stops the heart right away, like if and that's sometimes more for younger people, but also if people are watching, it's more for the comfort of those watching, so it's fast, like it's just kind of happens, and it stops the heart instantly. So if this is going ahead, the pharmacy needs to know ahead of time what the drugs are being used for. They always send 2 sets of drugs. They have 2 intravenous lines, and the medication pickup and delivery is covered. So you're not, if you're having made, you're not having to pay for any of this. It's covered if you've got a health card. So the safeguard, so that people aren't just leaping into it, you do need 2 separate assessors that are separate and independent of each other. And natural death has to be foreseeable. So, and they used to have a 90-day waiting period. They no longer have that. And there's no longer a mandatory waiting period either if the 2 independent assessors feel that death is inevitable. There is a track 2 kind, and it's for patients whose natural death isn't necessarily foreseeable in the immediate future, so they would have a 90-day assessment period, so they would have to wait 3 months and then do the assessment again. So because this is only like 3 years old, that it's not that many people that have really done it, but mostly have been cancer patients, lung cancer, colorectal cancer, hematologic. Some people with cardiovascular disease have chosen it. And like who didn't get it? Well, some people actually died before they got it. Or they chose the palliative approach.